This
Okay, this.
conference will now be recorded.
I would say this is abnormal and should prompt, yeah, C.
Oh, sorry.
I mean, that's what I was going to say.
Sorry. I
Trust me.
accidentally clicked on the screen when I was trying to record. But yeah, definitely abnormal. You want to think about, is there some small intimal flap that's causing a little platelet thrombi to be flicked off and cause this person to have amaurosis? Okay. These are so. Who else is on here? I'll stop picking on Johnny. Lydia, have any thoughts on this question? Tears and organ.
I think it's A.
It's actually B, which is kind of scary to think about because I think sometimes we think TIAs are not a big deal, but a lot of that risk is up front. So why the benefit of carotid endarterectomy people have TIAs. Let's see. Oh yeah, okay. So a few questions about bilateral carotid stenosis. Lydia, if you don't mind sticking with this. So an 85-year-old man presents with right eye amaurosis. He has normal sinus rhythm, and his carotid duplex demonstrates 50% stenosis on the right and greater than 80% stenosis on the left. What should his treatment algorithm include?
All right, let's see. All right, so it's always the aspirin and statin, and then do the symptomatic side first. So
Exactly.
it's C.
Exactly. And then so I don't think I don't have a question on it, but then so if they're bilateral asymptomatic, the other concept to take home is that you would generally do the tighter side first. And if they're bilateral asymptomatic and symmetrically stenosed, then you would do the side that perfuses the dominant side of the brain first. So in a right-handed individual, you would probably do the left side first. And in a left-handed individual, you'd probably do the right side first. Lydia, which of the following patients is at the highest risk of cerebral hyperperfusion syndrome?
So I think it's B with the bilateral high grade.
Yeah, just the more likely one is to present with that. Awesome. Okay, this topic, let's go to Todd. If Todd is there and can hear me, a 24-year-old patient presents after an attempted hanging episode, complaining of neck pain. Their GCS 14 on arrival with stable vital signs, and their neurologic exam is normal, but for right-sided meiosis and ptosis, which of the following would explain these findings?
Let me see. I'll go with C. Synthetic nervous system.
Yes. Yeah, so not actually necessarily a vascular injury, but it could be, because you can also have a carotid dissection that will impinge upon the stellate ganglion and cause a relative Horner's, but more workup to follow. And then this question, I think the answer might be a little bit controversial, but do you have any thought as to which of the following blunt carotid injuries has the highest risk?
Go with, I'd be guessing, but I would say pseudoaneurysm.
Right. So the point being that if someone presents with a complete thrombosis and they are asymptomatic, they're unlikely to become symptomatic because they've already had such a bad injury and they're declaring themselves that clearly they can perfuse through their circle of Willis. Patients with dissection are at risk, but patients with pseudoaneurysm are ones that can have kind of a cul-de-sac phenomenon and accumulate thrombus within that pseudoaneurysm that then flips off and has a very high risk of associated CVA. And then these are just the carotid injury grades. Some people call it a Biffle grade. Just important to review, really more so for trauma, but also just important to have in the back of your mind when you're talking about vascular injuries and treating blunt cerebrovascular injury. Todd, if you want to stay with this question, so a 32-year-old woman has 4 drug hypertension, and she's had a bunch of interventions on her renal artery. She doesn't really know what they are, but she presents now with 2 episodes of acute onset of numbness in her right arm that resolve after 3 minutes. Is there anything you're concerned about?
Yes, there is. Let me read these real quick.
That's good. That's a good answer.
It's getting at her vascular disease. I guess C would go C.
Yeah, and so I mean, as a background, is there any baseline diagnosis that you're concerned about?
Yeah, like fibromuscular dysplasia. So
Yeah, exactly. So you were concerned that she has intimal irregularities of the carotid. And then on pathology, what's the most common form of fibromuscular dysplasia? This is kind of a know it or you don't. I've never seen this come up on the ABSITE, but it's in every review book.
I'm just gonna go with medial fibroplasia A.
Yes, yep, that's correct. And then so a useful mnemonic for the vessels affected by fibromuscular dysplasia that some folks use is RICE, and it also is in the order of most commonly affected vessels, so the renals, followed by the internal carotid, followed by the intracerebral vessels, followed by the external iliacs. And you will see this occasionally. There's been folks in our vascular clinic that have followed up for surveillance of their cerebral aneurysms and other things related to their fibromuscular dysplasia. Okay, who else is on here? Sleater, if you're on there and listening, I'll give you this question. So 8 hours after a carotid endarterectomy, a 55-year-old gentleman develops a large neck hematoma and stridor. He's bradycardic and his oxygen saturation is dropping. What should the next step be?
So I'm driving, so I'm not able to read the answers.
Oh, I'm sorry. Okay. Well, so if you were to decide between intubating the patient, opening the neck incision and evacuating the hematoma, performing a bedside tracheostomy, mask ventilating the patient, or doing a nasotracheal intubation, do any of those sound better than the others?
So the first thing I would open the incision, and then you would control the airway.
Yeah, absolutely. And then Bobby, can you tell me, why do these people get, why can't they breathe? Is it is the hematoma just so pressurized? Like, do we have a leak from our patch site, or why do these people get the inability to breathe just from a little neck hematoma?
Great question.
It compressed the venous structures in the neck, creating like laryngeal edema and
yeah, exactly. Exactly. There's obstruction of venous outflow. That's perfect. So this is a question that I've never seen on there, but it's the Crawford classification of thoracoabdominal aortic aneurysms. I don't think it's something we necessarily have to know, but it's in there. So let's see. Who's on here? If Flynn can see this, so a 50-year-old female undergoes a hysterectomy that's complicated by a left femoral popliteal DVT, treated initially with IV heparin. Post-op day 5, though, she has a pulseless right lower extremity for which an embolectomy is performed and demonstrates a large amount of white clot with breast back bleeding after you perform your embolectomy. The treatment should include which of the following: a heparin bolus and maintenance, a pelvic angiogram and angioplasty of any culprit lesions, fem-fem bypass, or initiating IV direct thrombin inhibition and avoiding further heparin exposure.
I have no clue.
Okay. So if you sometimes when they talk about white clot,
venous thrombosis.
does that suggest anything to you if they talk about an evacuation of white clot maybe 5 days?
Yeah, I don't know what that is. I've never heard of that.
It's really dense fibrin, and it's kind of a hallmark for.
No, I've never heard of that. Yeah.
Okay, for like someone who's having HIT. So if you were to think that she has HIT, what might you consider doing?
Oh, okay. Avoid heparin.
So not A, right? And then it sounds like she's young.
So
she has
probably
risk
maybe D.
ovulating. Yeah, D is correct. So there's not really anything to go looking for on a pelvic angiogram. There's not really anything, doing a femoral bypass in someone who does not have native arterial disease is not really a fruitful endeavor. And then, but yeah, you want to initiate a direct thrombin inhibitor, which is really the treatment of choice for initial management of HIT and other acute arterial thromboses in a similar fashion. So this is a little bit different, but still sticking with anticoagulation. Glenn, if you want to take this one too. So a critically ill patient in the ICU has multi-system organ failure to include ARDS and specifically liver failure. They develop heparin-induced thrombocytopenia on hospital day 9. Which direct thrombin inhibitor should be given?
There. No. Am I unmuted? Okay.
I'm sorry. I'm having trouble.
I think it's argatroban.
What if they have liver failure? Is there any? So argatroban is what if I told you it's hepatically metabolized? So the last 3 are not thrombin inhibitors.
Well, then it would be B.
Yeah, bivalirudin. So you nailed it. So prasugrel, clopidogrel, those are antiplatelet medications. Integralin is really kind of an antiplatelet medication as well. So next question, back to Bobby. 2 weeks after an aortobiofem, a 67-year-old guy with chronic renal insufficiency presents with acute right lower extremity swelling. Duplex demonstrates femoral popliteal DVT on the right. He started on unfractionated heparin, but 24 hours later, he has a significant platelet nadir. What would be the next best step in his treatment?
So worried about HIT again. Classically, we switch these patients to argatroban. I don't see any contraindication to do so.
Yeah, that's good. What about, so Flynn just answered bivalirudin on the last question. That's also, it's not a bad drug. We've used it on other patients. Is there any reason this guy could not get bivalirudin?
Oh, yeah, because his renal disease. So
Exactly. So this would be a case where you use argatroban. So just a brief slide about heparin substitutes. Argatroban is a direct thrombin inhibitor that is contraindicated in patients with significant liver disease, and then bivalirudin is cleared by a combination of renal and proteolytic cleavage, but it's relatively contraindicated in the setting of renal insufficiency. I'll change to Tassan now that he's free and done tending to Quinn, but a 44-year-old woman presents with left lower extremity ischemia. She's found to have an occlusion of the left femoral artery. She's taken emergently to the operating room for an embolectomy. And on follow-up of the path, the clot reveals spindle cells. Is there any further management that's required?
I think D.
Yep.
An echo.
Yep. Yeah, so
Because
they're
you're looking for like a myxoma, right?
Yeah, exactly. Either myxoma or an angiosarcoma as the source of that thrombus. So you want to get a TEE. And it's actually important that a TEE would be best, right? Because these are most likely to form in the left atrium, the most posterior chamber of the heart. So that's going to be best visualized with a transesophageal, not transthoracic echo. I got David's daughter.
She's really excited about it.
She agrees. If you want to stick with this one, so an 80-year-old woman presents to your office with dry gangrene, and she has the comorbidities listed, which include hypertension, hyperlipidemia, diabetes, coronary disease, AFib, and CKD stage 5 with a GFR of 15. After a full evaluation, you plan to perform a percutaneous intervention. And what would be her most significant risk factor for contrast-induced nephropathy?
I think it's either D or E, her baseline GFR or the amount of contrast given, and I'm going to say D.
That's correct. Yeah, D. Sorry, I think there might be a little delay in my slides, but yes, D is correct. And then if you were to try to mitigate that risk, what would be the best management strategy for that?
I would do normal saline hydration and N-acetylcysteine, A.
Yep. Yeah. So there's some newer data that I guess N-acetylcysteine doesn't actually do anything, but that's fine. It might not make it to the ABSITE yet, but yeah, it's just IV crystalloid hydration. There's nothing special about bicarb. You don't want to give them theophylline, definitely, and then furosemide would not be helpful either. Okay, let's see who else is on here. I might just have to go back to the top. Oh, I don't know if I showed that answer, but Lydia, if you want to take this one. So a 75-year-old gentleman presents to the emergency department with acute limb ischemia in the setting of new onset AFib. He undergoes an emergent embolectomy and 4-compartment fasciotomies. In the ICU, he has a hematocrit of 32, creatinine of 2, potassium of 4.5, FeNO of less than 1, and a CK of greater than 28,000. He's only produced about 20 cc's of red urine over the last 2 hours. What would be the most appropriate next step?
So it would start with fluid resuscitation, C.
Yeah. And then this is going to be another ICU patient. So after you get finished resuscitating him, you have this 78-year-old woman who has a known 6-centimeter AAA who presented to the emergency department with back pain, syncope, hypotension, anemia, and a lactate of 5. She undergoes a successful EVAR placement and is transferred to the ICU. She eventually requires a total of 10 units of PRBC, 6 of FFP, and 8 liters of crystalloid. Her hemoglobin is now 10. PTT is 50, her creatinine is 2.9, and she's only made 10 cc's of urine since the operating room. Her EKG shows normal sinus rhythm and no ST segment elevations. Her MAP is low. On an FiO2 of 100%, her PaO2 is only 65, and her peak pressures are 45. Is there any diagnostic test that you would use to confirm her clinical diagnosis?
Bladder pressure, C.
Yes, perfect. And then there's a slide in here that I don't think is super useful for the review, but just some factors to keep in mind for risk of abdominal compartment syndrome being lowest blood pressure, a patient who presents unconscious, a patient who requires at least 5 liters of resuscitation, needs an aortic occlusion balloon, or if done open, needs the reimplantation of at least 1 renal artery. Those are all things to keep in mind. Lydia, if you don't mind continuing on. So a 37-year-old woman is 34 weeks pregnant. She presents with aching in her left calf and some edema of her left lower extremity. She has mild shortness of breath after walking up a flight of stairs and has had pleuritic chest pain. Her vital signs are normal, and a venous duplex demonstrates a femoral popliteal DVT on the left. What would be the most effective management for this patient?
All right, so not anything involving warfarin.
Yes.
So I think it's C.
Yep, perfect. And then, sorry, David, are you saying something?
Yeah, I was going to ask, where does all this talk about bed rest come from? Because that's totally counterintuitive, and I don't know if there's a particular reason they put that on there, but that doesn't really make any sense to me to put somebody with the DVT on bed rest.
I would also not do that. I think it's an antiquated recommendation that lots of pregnant women receive when they have any number of ailments that don't actually benefit from bed rest. They get put on bed rest. But all I can say is parts of this were made back in 2015. So I don't know if maybe the recommendations were different then. But the other take-home point is that warfarin is either teratogenic or an abortifacient, and so it should not be given to women that are pregnant.
And so do you just presume that she has a PE with her shortness of breath and pleuritic chest pain, and you don't need to scan her because you just give her anticoagulation anyway?
Right, and yeah, exactly. That's the other take-home point. Sorry, is that honestly, whether or not she has a PE, does not change your management because her vital signs are normal. So she is certainly not having a massive PE, and then she has no indication of necessarily having right heart strain. But even if she did, she would just get anticoagulation for a submassive PE. But she's probably best characterized as having a non-massive PE, and so the management of that would be identical to just an isolated DVT. So you can skip the whole need for a CT scan, any discussion of radiation exposure, shielding, and anything like that. So just the diagnosis of the DVT is sufficient to start treatment, especially since she's pregnant. Okay, I don't think I've asked Clem to chime in. So Clem, if you don't mind, which of the following is not an approved indication for a IVC filter?
All right, A would be an indication. B could potentially be an indication. I would say C is not an indication because they're subtherapeutic on their for their INR. D would be an indication, and E as well.
Yeah, exactly. So this person has not truly failed their medical management if they have not reached a therapeutic INR in the first place. So, sorry. And then, Clem, if you don't mind sticking with this, a protamine reaction is more common in which of the following patients?
I believe it's all the above on this one.
Yes, yeah. And so just a little slide about that. It's typically dosed 10 milligrams per 1,000 units of heparin, or 1 to 100 is probably easier math to do. And then it truly presents with kind of like an anaphylactoid reaction with systemic hypotension, bronchospasm, and associated pulmonary hypertension. The reason that fish allergy is associated is derived from salmon sperm. Patients who have had prior vasectomy develop their own sperm alloantibodies. And then the P in NPH insulin is actually protamine. So those patients have previous sensitization. So just the 3 things to keep in mind when you're asking for your anesthesiologist with protamine, and then asking why the patient is hypotensive because they bolus dose it before giving a test dose. But Bobby, if you don't mind picking up some of these vitamin K dependent factors, just kind of know it or you don't.
Yeah, it's 2579A.
Which one is it?
C.
B, 25710.
So it's 27910. So C, 27910.
That's 11.
Yeah, that's a typo, but 27910. So this question will get some work. And then absolute indications for an IVC filter include all the following except what?
D.
Correct.
Positive DVT in the sudden pregnancy.
Yeah. Let's see. I'm just picking on Bobby here. All right. So Todd, a patient undergoes aorta bifem that's complicated 8 hours later by right graft limb occlusion. He complains of severe pain and has intact motor function but diminished sensory function, and it's unknown how long the graft limb has been occluded for. What treatment option would be best? All right, maybe not.
Sorry, I was muted.
Well,
That's why I was muted.
okay.
I was talking.
It's okay.
But I was saying I'm really not sure if this is going towards like compartment or not. I feel like if I was taking a test, I would say A, but I don't know. I'm not sure.
So I would, the key takeaway points being that you don't know how long this has been down for, but he's having some diminished function. So you definitely need to go back and reopen the graft. And then I would have a very low threshold for a 4-compartment fasciotomy because you don't know how long this has been down for. and the likelihood of him having some component of compartment syndrome or just acute limb ischemia with eventual washout and subsequent reperfusion injury and development delay compartment syndrome is also a risk. So D is probably the best answer in this case. This question is a little bit controversial. Johnny, if you don't mind taking it, a 52-year-old previously healthy man presents with acute right lower extremity ischemia and an absent right popliteal pulse. Is there any initial emphasis on initial, I guess, diagnostic test for the workup of this patient?
So an absent popliteal pulse, so you would assume that the pathology is proximal to that. You would not get an MRI. I would not get an ultrasound of the popliteal, given what I just said. Cardiac echo would be assessing for like an embolic source. I'd probably get a CTA, but I think what this is leading it to is an arteriogram.
Yeah, I think that's really reasonable. I don't know why Dr. Arthur said to start with a popliteal ultrasound. I think it's primarily because this patient's otherwise healthy and they have an isolated absent popliteal pulse. So the thought being that you could easily rule in or rule out a popliteal aneurysm. I don't think that we would see a question that's kind of this controversial on the ABSITE. Next one is probably a little bit more useful. So an arteriogram, that you suggested, that the patient eventually gets to, shows a focal occlusion at the adductor hiatus with an embolus. They undergo an embolectomy, and is there any other tests the patient should have included in their workup?
CTA.
So you've already done your arteriogram, and you have an embolus in a patient who was previously described as, he does not necessarily have AFib.
I guess yeah, you need to image the chest. I guess I didn't read that closely enough, so I think they're getting an echo.
Yeah, exactly. So you have to look for a source of that embolus, especially an intracardiac source. These are just some kind of know it or you don't questions. It's a little more basic science. If Flynn, if you want to take this, I'm sorry, go ahead. Did Clem just shout out B or something? Okay, endothelial cells. Johnny, if you want to do this one, a 32-year-old gentleman stains a stab wound to the right medial thigh. He has a tense hematoma. On exploration, there's a distal SFA tear with a small focal thrombus. What would the proper management include?
Did you ask me because I'm 32?
No, I just figured you'd done some of these before. It's unfair to ask people who haven't repaired some of these.
David, Johnny.
So, but you did nail that.
So a near transection with a small amount of thrombus, you would need thrombectomy, debridement, and anastomosis. Sounds like a small injury. You can do primary repair.
Yep. And then a couple additional questions. So in the ER, they talk about this patient having a tense hematoma. Flynn, are you familiar with any like hard or soft signs of vascular injury that you would be considering when you're evaluating this patient in the emergency department? Sorry, if you're doing other work, I can just.
She's working on it.
Okay.
Can you tell them if my sound's not working? I can't get the thing unmuted. Can you hear me?
Okay. Yeah,
okay, now you
that's fine.
She's got it.
I'm sorry. Let's see. Hard signs of vascular injury. I feel like aren't these the things on like the pivot form in the
I don't know, honestly.
Like
I don't know. They've been
like
around
like active bleeding. Yeah.
Hard signs being an absent pulse, pulsatile bleeding, expanding or pulsatile hematoma, bruit or a thrill. Soft signs being what?
Mm-hmm.
So soft signs would be like a non-expanding hematoma, a palpable but subjectively diminished pulse.
What? I can't hear them though.
Okay. And then a few things about proximal and distal control. So I have some slides to follow about femoral artery and above knee popliteal exposure. The point about knife versus gun. So in Johnny's question, it was a focal incomplete transection from a knife that could be primarily repaired. There's almost no penetrating injury from a gun that could just be primarily repaired because of the relative destruction of the artery. And then the best conduit would be vein. And if there's injury to the ipsilateral vein, you would try to repair it, but if not, you can just ligate it. So these are a few slides on femoral exposure and kind of the technique. And then on a medial approach to the above knee popliteal artery, which is going to be kind of the workhorse approach, especially for trauma. So von Willebrand's disease, primarily diagnosed with an increase in bleeding time. A slide about that. Platelet to subendothelial collagen is primarily going to be related to the glycogen 1B receptor. We'll kind of just move through some of these because they're kind of know it or you don't. Which medication blocks the ADP receptor on platelets? That's going to be Plavix or clopidogrel. Sorry, it looks like the slides are a little behind the narration. Okay. So who's on here? Clem, you want to take a stab at this?
Yeah, I'll do it.
Patient underwent an AXFEM 3 months ago. They now have purulent drainage and exposed graft in the left groin wound. Gram stain returns negative for any organisms, but what is the most common infectious agent 3 months out?
Staph epi.
Yep. And then in general, it is the most common infection of any graft. And then staph is going to be your #1 cause for mycotic aneurysms. And then second is kind of that classic answer of salmonella. This is a vascular lab question. So resistance in series is additive is the point that this is trying to make. Unlikely to show up on the ABSITE. Okay, a few more basic science questions. Todd, you want to take a stab at this?
Yeah.
What's the mechanism of urokinase?
So that's going to break down. That is. Forget which one it is. I'm going to go with. It's not D. C, activates plasmid.
It should be B. It'll convert plasminogen into plasmid. C is kind of another way of phrasing that, but the point is that it works here and completes that conversion. So next one, more of a exam finding. So a patient presents with an acutely ischemic left lower extremity. There's a line of demarcation on the proximal thigh with temperature changes and modeling distal to that kind of line of demarcation. What would be the most likely level of occlusion?
So I believe you go like level above, or maybe common iliac.
Think a little lower. Like there's nothing involving their buttock, so it's just thigh.
Okay, just external then.
So even further, you could think like proximal SFA.
Okay.
Yeah. Let's go next. So what would be a, Todd, if you don't mind sticking with this, an increased risk factor for warfarin?
Hey, Nissan.
Protein C deficiency.
Yeah.
For that last one, I think it'd just be good to make sure. Hey, Todd, what supplies vascular supply to the thigh? Is it the SFA or the profunda?
The thigh would be SFA.
Try again.
Profunda.
Yeah, so the SFA is basically like an inline vessel to the lower leg, and so I that's the point of the question. Why it's not the external iliac and it's the SFA.
Okay. Yeah. Wait, but following that logic, shouldn't the thigh be preserved and then everything? You said proximal thigh.
The thigh is preserved in this.
The line of demarcation over the proximal thigh. Like I take that to mean like right near like the takeoff, like at the profunda. I mean, I'm just being parsing the question now, but like that's why I'm thinking like, wouldn't you want something a little more proximal to the proximal SFA to give you this delineation? Or, I mean, this may not be a distinction that is relevant right now.
I don't know. I guess, yeah, I don't know exactly what was meant by proximal thigh. I guess exactly where they're imagining it is the only.
Like
thing
if they said like
but,
mid or distal thigh, that would make more sense to me. But
yeah, I thought it said distal thigh. I'm not gonna lie.
That's fine. I mean, I guess so. So first and foremost, an isolated occlusion of the profunda would probably have really kind of, it would not totally present like this. You would have some collateralization, so that's out for E. External iliac is not an unreasonable choice.
Yeah.
Common iliac, to your first suggestion, Todd, that would present more so with like buttock claudication and buttock pain, and maybe even like groin pain. And skin changes. Aorta would obviously be bilateral lower extremity, so just kind of like you were saying, a level above. But yeah, I don't have a great reason for why it's not like distal EIA as opposed to proximal SFA.
Yeah, if I'm kind of with you guys. If I had not had answer choices, I would have said common femoral for this.
Right.
Yeah.
So I don't know.
And just to be clear, it's not that the SFA doesn't have branches to the thigh. I just wanted to point that out.
Todd, warfarin-induced skin necrosis?
Protein C deficiency.
Yes, very good. Just some half-lives of various factors for what it's worth. And then Todd, a 16-year-old woman starts OCPs and develops a femoral vein thrombus. Her primary care provider sends a hypercoagulable. What would be the most likely condition?
I believe the most common one is factor V bleeding.
Yep, exactly. Yeah. So this is a slide to that effect. Just showing that factor V bleeding is kind of overwhelmingly the most common heritable hypercoagulable condition. Okay, so some matching. Who's on here? Let's see.
I can do it if you want.
Johnny, can you see this? Or yeah, go ahead, Clem. I don't know if the mobile folks have their screen up, but yeah.
SVC syndrome is going to be the last one, so headache and conjunctival edema. Paget-Schroeder is going to be unilateral arm pain and swelling. Nutcracker syndrome is going to be varicocele. May-Turner is going to be left iliofemoral DVT from compression from the right common iliac artery. And then popliteal vein entrapment is going to be B, varicose veins below the knee. I think can be from a number of causes, like 3 different kinds.
Yeah. All right. This is just a question about size thresholds for intervention on abdominal aortic aneurysms. So Clem, if you don't mind sticking with this. So a 7-year-old woman has a 4-centimeter asymptomatic aneurysm. She undergoes annual surveillance ultrasound, and referral for repair should occur when the diameter is at least what?
This is a man, so it's going to be D.
Yeah. I said woman, but yes, it's a man. Yeah.
So 5.7.
Yeah. So generally speaking, your referral thresholds for an EVAR for a man would be about 5.5 centimeters. For a woman, generally about 5 centimeters. And then for open repair, it kind of depends. Some say the same threshold. Some say you can let it go to as high as 6.5 because the high risk of perioperative morbidity and mortality for open repairs. So Clem, 78-year-old woman, or 78-year-old man presents with a single episode of hematemesis. He had an open abdominal aneurysm repair 4 years ago. EGD shows some clot in the third portion of the duodenum, and a CTA reveals a fistula between the aorta and the duodenum. So what's the most appropriate treatment?
Yeah, so this is a Harold bleed. Like you said, he has an aortoenteric fistula. It's going to be D.
Yep. And then who else is on here?
I think you can limp, if this person was unstable, I think you could limp them along with maybe an like an EVAR, like a stent and a stent to get them through, but that's not going to address the issue, which is that it's going to become recurrently infected and a problem again. I don't know if that would come up on the ABSITE.
I mean, I guess the only setting in which I could see that come up is if someone was, like truly unstable, and maybe they're like just actively completely hemorrhaging out of their GI tract, or they're just in, totally florid sepsis and multi-system organ failure. Not that that will totally control the sepsis, but that it will just exclude one thing from another, and then you can work on getting them better. But I think overwhelmingly the other point that they want to hear is an extra anatomic bypass.
And just to reiterate that point, the point of that is similar to other surgical principles where there's a piece of prosthetic material in there. There's GI, flora, other things that are getting infected. So that has to come out, and then you try to get a new graft in fresh tissue planes. And if you could use vein, that'd be great, but you're often not going to find vein long enough to do like an aorta bifem. So that's kind of
right. You wouldn't really be able to do an aorta bifem because that would be an infected field, right? So your go-to extra anatomic bypass for that patient would probably be an axe bifem.
Sorry, that's what I meant, not an aorta bifem, an axe bifem.
Yeah. But yeah, exactly. So vein is very unlikely to work. So you probably are going to end up using some prosthetic. Let's see. So Johnny, if you don't mind taking this, so a 75-year-old man returns 10 years follow-up after an EVAR. His AAA initially decreased in size, but now it's grown, and there's some contrast filling outside the distal limb of the left iliac. So it's asking what type of endoleak does he have?
It was like they're getting at like a type 1B filling the distal limb from the distal limb.
Yep. Perfect. This is a relevant slide, just kind of illustrating that. And then there's not a question about this, but Johnny, do you know the types of endoleaks that if they're diagnosed in the OR, you need to fix them before you leave the OR?
Right. So the types 1 or 3, and really it refers to the aneurysm sac seeing arterial pressure. So if there's a leak at the proximal or distal aspect, it's going to see arterial pressure into the aneurysm sac, and it'll continue to expand. Mm-hmm. Or if there's like a defect in the graft itself where the components haven't come together, you're going to get leakage of arterial pressure. Type 2 is the one that it's like back bleeding from an IMA or a lumbar, that it's not like pulsatile arterial pressure, but they will typically observe those even if they see them in the OR initially. But actually this week we're intervening on a type 2 endoleak 3 years after, because he's had slow enlargement of his aneurysm sac. So that's the only time you intervene on those, is when they actually cause enlargement over time. And then the type 4 apparently is not really an issue anymore because the new graft types have addressed this. And then type 5, every research, I mean, like you listen to Behind the Knife and they don't even like go into it because they say they don't understand it, but really it's like enlargement of the aneurysm sac without a cause, an identifiable cause.
Yeah, that's perfect. So yeah, the 1s and 3s are the ones you fix early. The 2s, I mean, it'd be very unlikely that you would even diagnose a 2 at the time of your initial intervention. That's something that it's, collateralization. 4, like Johnny mentioned, is a decreasing problem, and then 5 is, I think, kind of thought to be related to the non-laminar flow, and so you get this kind of exudate across the graft material, but I don't know that is necessarily clinically relevant compared to really it's just might be a missed type 1 through 4, and so people are calling it a 5. But I don't actually know why this made it into the PowerPoint, but I wasn't going to take it out. So Johnny, if you don't mind, what's the most common cause of death following a cardiac transplant?
I think it's going to be accelerated atherosclerosis.
Yep. Yeah. And that's a little different than chronic rejection, which we think of as like a vasculopathy in the bed. These people, in addition to chronic rejection, also get accelerated coronary atherosclerosis. And then which of the following would be an absolute indication for carotid subclavian bypass after a TVAR that involves subclavian coverage, or really before, excuse me, a TVAR that involves subclavian coverage?
The previous Lima to LED bypass.
Yep. And then, so these are the 2 most common kind of hard indications for a preoperative carotid subclavian bypass. Basically, any others can be symptom directed and can be done on an as needed basis post TVAR. And then another thing to consider is that somewhere around 3% of patients will have an anomalous left vert that arises directly from their arch. Who else is on here? Toss in if you're free. So you have a 21-year-old who presents after a motorcycle collision. He's 5T, tachycardic and hypotensive. He has bilateral breath sounds, but the pelvis is unstable and is secured in a binder. His chest x-ray shows an enlarged aortic knob and a widened mediastinum, but bilaterally clear lung fields. His FAST is positive in the left upper quadrant, and say he remains hypotensive. So what would be the most appropriate initial step in his management?
Hypotensive with a positive FAST. He goes for a laparotomy.
Absolutely. Yep. And then, so now you have a 20-year-old woman after a motor vehicle collision who's also GCS7 with DAI and a blunt aortic injury amenable to TVAR. She is not hypotensive and her heart rate is controlled on an esmolol drip started in the ED. But what would be the best management for her?
She gets an early TVAR C so that we don't have to do strict double product control, which would be bad for her brain.
Yeah, perfect. So the take-home point of those questions really being that patients who have aortic injuries that are lethal really kind of self-select, and it is safe to wait up to 72 hours to repair them while addressing their other life-threatening injuries that are actually going to be more life-threatening in the short term. The one exception to that being the patient with a severe TBI in whom you want to take strict blood pressure control off the table and be able to artificially elevate their MAPS. And so those patients should get early TVAR. David, if you don't mind this one as well, an orthopedic surgeon is performing an L4-5 laminectomy with the patient in a prone position and notes a bright gush of blood. They pack the wound and call for your help. What should you do to address the bleeding?
Let's see, I'm not 100% certain. I would guess he got like, a lumbar artery. Let's say C, but I'm not sure.
So I think what they're looking for is more like an iliac or a bifurcation injury, and so they want you to actually roll the patient supine and
I see.
And go for a conventional approach rather than work through the limited approach that the orthopedist is offering. Whether it's just packing the wound and IO-banding it and then flipping the patient, but I think they want you to take a conventional approach to a possible vascular injury. This is another kind of unconventional question, but during an elective lap gastric bypass, the 12mm port is aggressively placed into the cable bifurcation and immediate laparotomy is performed. The best approach to this cable bifurcation to repair this injury would be what?
Oh, sorry, hang on.
That's fine.
Sorry, I'm going to say
That's all right.
A, mobilizing the vena cava 5 centimeters above and below.
Yeah, so this I was a little surprised at, but it's almost like thinking of May Thurners. They want you to just divide the iliac artery to be able to get right at that bifurcation, repair it, and then repair the iliac artery. I don't know that they would ask us to do that on the ABSITE, or if non-vascular surgeons would be as aggressive in doing that for what that's worth. But
that sounds a little.
Yeah, a little bold. This is just getting at which of the following patients would be highest risk for postoperative cardiac events. Not the greatest question, but the point being that an audible S3 on cardiac auscultation is getting at a risk of heart failure, and that's the single greatest risk factor for postoperative cardiac event. And then a medication shown to reduce mortality in patients with heart failure being ACE inhibitors, which if the renal function can withstand is a worthwhile medication to make sure everyone is on. These are some basic ACC guidelines. Okay, so who is still on here? Bobby, do you want to tackle this question? So a patient has a mechanical mitral valve and they're planning to undergo elective lap chole. What should management of their Coumadin entail?
All right. So just for an elective lap chole, probably want to. We don't need to reverse them. Probably bridge them. Is it B?
Yes, yeah. So the point being that the presence of a mechanical mitral valve is probably essentially the highest risk patient unless they had an additional low EF or some other factor. But these are the few kind of subset of patients that it's still worthwhile to stop Coumadin a long way out and do a true heparin bridge with early restarting of Coumadin as soon as it's safe. If the patient had an aortic valve, if it's just mechanical and not in the presence of a low EF, they can just have their Coumadin stopped about the same duration, 3 to 5 days prior to surgery, and they do not need a heparin bridge. And then this is just the reference for that for anyone interested. And then, okay, so some visceral artery aneurysms. Bobby, a 45-year-old man is found to have a 3 centimeter common hepatic artery aneurysm. He's asymptomatic. What should the treatment include?
So you generally want to fix visceral aneurysms in the common hepatic greater than 2 centimeters. So depending on, I mean, there are a couple of different ways to do that. You can exclude it with a stent. Doesn't seem like they want to do that. You could also resect it and bypass it. So
yeah. Well, and are there any downsides to placing a stent in the common hepatic artery?
I mean, it's got a lot of gives off a lot of branches, so you could potentially cover
right.
one of those.
Right. Things like the GDA, or depending on where their right gastric artery comes off. So really important stuff that a stent, because you're not using an uncovered stent, could be pretty high risk for. So surgical resection with bypass. And then, so which of the following splenic artery aneurysms would be the best candidate for repair?
So you generally, classically resect, again, repair these or exclude these in pregnant females or women of childbearing age and greater than 2 centimeters to C.
Yeah. And then any reason that you actually are not that worried about patient in choice A?
Again, these splenic artery aneurysms have a very, in general, low rate of rupture, but the risk increased dramatically in pregnancy. And
yeah,
so
the thought being she's kind of self-selected, right? She's lived through her childbearing years with this aneurysm, is no longer having exposure to high levels of estrogen. So might you discuss fixing it? Sure, but it's not that high risk because this patient is kind of self-selected. Sorry, there's a couple things in the chat. Oh, consult the coroner. Jesus Christ. Okay. Where does a replaced right hepatic artery typically arise from?
Let's see.
Yep. And then how frequently?
No, I think I replaced left is 10%, so I don't, maybe less than that, 5 to 10.
So replaced right is the most common kind of splanchnic vascular abnormality, and so it can occur in, depending on what you read, as much as 20% of individuals. Let's see some anatomy stuff. Todd, are you available? So where does the carotid lie with respect to the jugular vein within the sheath?
Posterior medial.
Yep. Oh, and then I just showed that, but so the most common splanchnic artery aneurysm is splenic. this is a little bit more of a chief level question. Is Clem, you want to tackle this? So a patient presents with thrombosis of their bilateral common iliac arteries and distal aorta. The bilateral CFAs are open via collateral flow, and he has short distance claudication with a task D lesion. Which of the following would be the best option?
Yeah, so task D is not typically amenable to endovascular options. I think the challenging thing here, and the one that I always forget, is kind of the difference between end to side and end to end. I think in this guy's case, I would do the end to side because he's thrombosed, and you would have to resect it. That distal portion.
Yeah, it's tough. I mean, I think frequently folks that have thrombosed aortas have small caliber aortas, and so an end to side is a technically easier anastomosis, is my understanding. But the problem is you don't that thrombus, because it has no outflow, it can continue to propagate higher and higher. So if you should really exclude it. You should really exclude it and do an end-to-end anastomosis. The hardest indication for an end to side anastomosis, as I understand it, is someone who has really not aortic disease, but bilateral complete occlusions of their external iliacs, because if you do this, you will make their pelvis ischemic because they won't be able to backflow. So it's the patients with bilateral external iliac artery occlusive disease that's complete that should get an end to side anastomosis, so they can continue to get inline flow to their hypogastrics and their pelvis, and then they can get their bypass flow to their common femoral arteries. Next is okay, yeah. So Clem, I guess if you don't mind sticking with this, a patient presents with acute abdominal pain and history of AFib. It began 2 hours ago. The pain is out of proportion to exam. What would be the next step in their evaluation?
So it sounds like she has an embolic acute mesenteric ischemia. I would start with the CTA.
Yeah. And then so this is what their CTA shows. Let me know if that is I think that's displaying. Okay. What would be the next immediate best step for this patient?
Be systemic anticoagulation.
Yep. And that's something that, you know, I think we've had this discussed on some oral boards stuff, and it's easy to forget. You know, you start resuscitation, you spin up the OR, but you can get their heparin bolus down in the ER before they ever get upstairs. So systemic anticoagulation. And then what would be the most appropriate next step?
The operative embolectomy. And I think the other thing that this is a good example of is that the middle colic often comes off before this narrowing for embolic disease rather than thrombotic disease. And so you can have some colonic sparing, which they like to test because it's a good anatomic question on ABSITE.
Yep. And then the same other point, I guess, is that, you know, this patient clearly does not have a lot of native vascular disease. So once you do the embolectomy, there's not a whole lot that needs to be intervened upon in terms of a mesenteric bypass. So Clem is correct saying embolectomy is the treatment of choice here. This might be the last question. A 77-year-old woman presents with 6 months of progressive abdominal pain, weight loss. She has epigastric and periumbilical pain an hour after eating, frequent diarrhea. Her previous physical exam and a right quadrant ultrasound were unremarkable. What would be the next step in her evaluation? Todd? Oh, maybe he's not there, or maybe he's muted.
I'm muted again.
Okay.
Sounds like they're getting at like a chronic mesenteric ischemia picture, so CTA.
Mm-hmm. Yep. Great. All right, guys, that's all I have. Thanks for bearing with me for a surprise hour and 20-minute ABSITE review. That's all I got. If there's anything else vascular relevant that people want to talk about, otherwise, I'll let you guys go.
Thanks, Alex.